Hi, myself Dr. Sudip Bonik Choudhury, specialist in internal medicine. This channel is made for improve your medical knowledge, especially the critical area of your clinical practice. If you want to improve your clinical side, especially medications and its tricks when you are using in clinical practice, please watch our video. Definitely you will be benefited. Thank you. Hi, myself Dr. Sudip, specialist in internal medicine. Today I am going to discuss regarding steroid. Steroid tapering is always a fascinating thing. Today I am going to discuss regarding this part. Whether we should blindly taper the steroid or we should not taper it at all. In some situation we need to do tapering, and in some situation there is no need to taper at all. Let us discuss these things in detail. Steroid tapering is always a myth. I hear this often, especially in busy ICU or busy wards. But here is the truth. Tapering is not a ritual, not a superstition. It is a tool, and like any tool, it is useful in some situation and unnecessary in others. In the next few minutes, I will give you a step-by-step, beginner-friendly framework to decide when you can stop abruptly and when you must taper, and how to taper it safely, without fear and without guesswork. Stopping steroids suddenly can be perfectly safe or dangerously wrong. Two risks decided the tapering. Two risks decide the tapering: HPA axis, suppression and disease flare. Now one thing we need to be clear. This video is for postgraduate medical educations. Steroid decision must be individualized based on indication, comorbidities and monitoring. Please use local protocols and senior guidance when needed. When someone says tapering is a myth, usually they mean we taper everyone without thinking. That part is true. That's the bad practice. Tapering is never required. That is also false. Tapering is not mandatory for every patient, but it is absolutely necessary for a subset, especially those with probably adrenal suppression or high flare risk. Hi everyone. Today's topic: steroid tapering. Steroid tapering is always a myth. I hear this often, especially in busy wards. But here is the truth. Tapering is not a ritual, not a superstition. It is a tool. And like any tool, it is useful in some situations and unnecessary in others. In the next few minutes, I will give you a step-by-step framework to decide when you can stop abruptly and when you must taper, and how to taper safely without fear, without guesswork. Stopping steroid suddenly can be perfectly safe or dangerously wrong. Two risks decide tapering. First one is HPA axis suppression and second one disease flare. Now, before using my video knowledge in your practice, you must remember that this video is for postgraduate medical education. Steroid decision must be individualized based on indication, comorbidities and monitoring. Please use your local protocols and senior guidance when needed. When someone says tapering is a myth, usually they mean we taper everyone without thinking. That part is very much true and that is a very bad practice. Tapering is never required. That is also false, because in some situation tapering is a required thing. So tapering is not mandatory for every patient, but it is absolutely necessary for a subset, especially those with probable adrenal suppression or high flare risk. The core physiology: hypothalamus pituitary adrenal axis, HPA axis. In 2 minutes I will give you a clear idea. Exogenous glucocorticoids reduce CRH and ACTH through negative feedback. Over time, adrenal cortex downregulates. So, if you suddenly stop after significant exposure, the body may not mount adequate cortisol response, especially under stress. Clinical outcomes to name clearly: steroid withdrawal symptoms. What will happen? Clinically, there will be fatigue, myalgia, arthalgia and low mood. In adrenal insufficiency, there may be hypotension, hypoglycemia, hyponatremia, even shock, particularly during infection and in surgery. Tapering is not about the habit, it is about giving adrenal axis time to recover when it is likely been suppressed. The two reasons to taper. Let us know, every taper decision is based on two questions. First one, HPA axis suppression risk. Has the patient taken enough steroids long enough to suppress adrenal functions? So you have to remember these things: enough steroid and time frame. Second reason, risk of disease flare. When you stop it, whether there is a risk of disease flare. Even if adrenal axis is fine, will the underlying disease rebound if we stop quickly? So the key important point is that sometimes we taper for the axis and sometimes for the disease, sometimes for the both. So step 1, identify the steroid dose and duration. See the drug, whether it is prednisolone, methylprednisolone, dexamethasone or hydrocortisone. See the route, which route it is given, whether oral, IV, inhaled or topical. Yes, high potency topical and high dose inhaled can matter. Duration and cumulative exposure, you have to see this thing also. Second step is categorize the exposure. Practical buckets, that is the bucket A, usually safe to stop without taper. Short course, less than 5 to 7 days of systemic steroid. Example, acute asthma burst, allergic reaction, short COVID era burst. And bucket B, sometimes we need tapering, around 1 to 3 weeks systemic therapy. Consider taper if high dose, repeated burst, fragile patient or strong flare risk disease. Then go for bucket C, taper usually required. Greater than 3 weeks systemic therapy or repeated course, or clear Cushing features and morning fatigue, prior suppression history. Now step 3, check for high suppression signals, higher daily dose, moderate to high, longer duration greater than 3 weeks, evening dose, more suppression, potent long acting steroids like dexamethasone, repeated burst close together, Cushingoid appearance. Now come to the step 4. Check the flare risk of the diseases. Certain conditions demand slow taper because the disease itself relapses. For example, vasculitis, SLE, IBD, nephrotic syndrome, pemphigus, autoimmune hepatitis, severe asthma, steroid dependent cases, certain neuroinflammatory conditions. So, if flare risk is high, you taper even if HPA suppression is uncertain. Now, how to taper? Practical patterns. Principle A. First taper at high dose and slow taper near physiological dose. From high dose down to moderate dose, taper can be faster. But once you approach physiological range, taper must slow. Physiologic cortisol equivalent is roughly around low dose prednisolone range. Near that, symptoms of withdrawal and adrenal insufficiency become more relevant. Principle B. One taper does not fit all. Choose a taper template. I will give you 3 templates. You can speak clearly. Template 1. Short course less than equal to 7 days. Usually stop, no taper. Template 2. Intermediate course 1 to 3 weeks. Option: reduce dose every 3 to 5 days dependent on indication and response. If flare prone disease, taper. If not, you can. 2-phase taper. Reduction phase, step down gradually to the low dose, and recovery phase, very slow taper near low dose. Assess symptoms, consider morning dose, consider evaluation of adrenal function if needed. Clinical teaching line. Most taper disasters happen in the recovery phase, not the reduction phase. Do we test everyone's adrenal axis? No. But in prolonged therapy, recurrent withdrawal symptoms, planned surgery, or unclear risk, testing helps. Morning serum cortisol as a screen, ACTH stimulation test when indicated. Stress, dose, steroid coverage during the major stress if suppression likely. So you have to remember, if you suspect adrenal suppression, do not prove it by stopping steroid abruptly. So common myths and how to debunk them. Tapering is always required. It is a myth, but reality is no, short courses often do not need it. Myth 2. If patient feels weak, it means disease is back. In reality, could be steroid withdrawal or adrenal insufficiency. Do not reflexively accelerate, reassess. Myth 3. Switching to dexamethasone is fine for taper. In reality, long-acting steroids can suppress more, often better to taper with shorter intermediate-acting steroids. So, myth 4. Inhaled or topical steroids never suppress, but in reality, Usually, minimal but high potency, high dose, prolonged exposure can contribute, especially in children and frail adults. Now, we can discuss some cases. Case number 1, a 28-year-old acute urticaria, prednisolone course for 5 days, stable, stop, no tapering. Case number 2, inflammatory bowel disease flare improved on steroids. If you stop abruptly, disease rebounds. Plan a structured taper. Start optimized steroid sparing therapy. Case number 3, SLE or vasculitis on steroid for months. Cushingoid features, needs slow taper and stress dose guiding during the illness. So in chronic inflammatory disease, the real goal is not an elegant taper, it is transition to steroid sparing therapy. So before you write tapering chart, check 6 things. First one, indications. Why steroids started? Then 2, duration. Then 3 number point, dose and potency. 4, route and timing, night dosing. 5th, flare risk of the disease. And 6th, suppression signals, upcoming stress, surgery, sepsis or trauma. So, if I summarize the whole thing, is tapering always a myth? Yes, but is tapering itself a myth? Absolutely not. So final 3 rule, short course usually stop. Long course or repeated courses taper, especially near low dose. Always think axis risk plus flare risk. So if you want, I will make a follow-up video, stress dose steroids in surgery and ICU. How to convert between steroid equivalents, steroid sparing strategies by disease. Comment your specialty, whether medicine, pulmonology, rheumatology, gastro or nephro, and I will tailor the next episode. Thank you.